I'm Dr. Paul Meli, Medical Director and founder of Meli Orthopedics here in Fort Lauderdale and Margate, Florida. I'm a board-certified, fellowship-trained orthopedic surgeon specializing in disorders of the shoulder and the knee. I'm the past chairman of the Department of Surgery at Holy Cross Hospital. At Meli Orthopedics, we treat all aspects of orthopedic injuries. Everything from the most common simple sprain strains to the most complex surgical procedures. We've assembled a team of highly trained, specialized orthopedic surgeons specializing in each area of orthopedics. Dr. Sarah Gibson is a board-certified, fellowship-trained physician specializing in the non-operative treatment of generalized musculoskeletal and sports medicine injuries. Dr. Lawrence Kempton is a fellowship-trained orthopedic surgeon specializing in traumatic injuries and their long-term complications. Dr. Aisha Livingstone is a fellowship-trained orthopedic surgeon specializing in the diagnosis and treatment of injuries to the hand and upper extremity. Dr. Richard Zavorsky is a fellowship-trained orthopedic surgeon specializing in hip and knee replacements, both partial replacements, total replacements, and revision joint replacements. Arthroscopic surgery is a minimally invasive surgical procedure where a fiber optic TV camera is placed within the patient's hip, knee, or shoulder. After placing the fiber optic TV camera into the patient's shoulder, hip, or knee, a thorough evaluation and treatment is able to be performed. Because the incisions are smaller, there is less pain, there's less anesthesia time, the patients typically are able to go home the same day. At present, with the advent of modern arthroscopic surgical techniques, all shoulder surgeries, with the exception of a shoulder replacement, can now be performed arthroscopically and as an outpatient. Since the arthroscopic procedures are now performed as outpatient, the patient can then begin physical therapy the next day, and the recovery is much quicker than the traditional open surgery. Some of the benefits of arthroscopic surgery include, as mentioned, the fact that surgery can be performed outpatient. The incisions are much smaller, typically less than ½ an inch. There's much less pain medication required. The surgeries now are all performed under an hour. The patient's able to rehabilitate in the comfort of his own home and then begin physical therapy the next day, and as a result, their rehabilitative process is greatly increased. With the advancement of arthroscopic techniques in knee surgery, all of the surgeries now in the knee, with the exception of knee replacement, can be comfortably and predictably performed as an outpatient. With the arthroscopic procedures being performed via a fiber optic TV camera with small incisions, the patient is typically on crutches only for a few days, is able to drive the next day, is able to begin physical therapy typically 1 or 2 days later. Even though the surgical procedures of both the knee and the shoulder are performed arthroscopically, it still requires a significant commitment for physical therapy post-operatively.
Arthritis occurs when the cartilage in a joint wears out, so the joint can no longer move effortlessly without discomfort. You can see how wearing down of cartilage affects the space between the bones. Patients often describe a sensation of grinding when one bone rubs against the other. Knees, shoulders, hips, and hands can all be affected by arthritis. Patients often experience intense pain, especially with activities such as walking, climbing stairs, and standing from a seated position. People with arthritis can also have limited motion of the affected joint. Moderation and modification of activity are important for reducing the symptoms of arthritis. For example, you may need to walk less, particularly if you do it for exercise. You may also have to avoid climbing stairs. Younger people may need to stop playing sports, especially those that involve quick directional changes like soccer and basketball, because they can cause a lot of discomfort. Over-the-counter medications are typically the first treatment option. These include acetaminophen, ibuprofen, and naproxen. For patients with arthritis in the knee, injections such as cortisone or hyaluronic acid may be used to decrease pain and improve knee function. When these approaches are no longer effective for arthritis pain, a patient may require surgery, such as replacement or reconstruction.
I'm an orthopedic surgeon, but I did a year of specialty training in the hand and upper extremities.
Hello.
Disorders, fractures, tendon ligament injuries, nerve damage, fingertip to shoulder, that's what I specialize in. Arthritis affects everybody eventually. Basilar thumb arthritis, which is arthritis in the base of the thumb, is the most common site of arthritis in the entire upper extremity from fingertip to shoulder. The first line of treatment, anti-inflammatories, bracing, is the same as arthritis in any other location in the body. We can do cortisone injections in that, and there is a surgical procedure, which is a joint replacement. My fingers sore in my palm area. When I make a fist, when I try to open it, all the fingers don't open the same. One kind of clicks and pops open, or they can't open it at all anymore. What that is just inflammation of the tendon or in the tunnel that the tendon glides in. I'd say about 80% of people are cured actually with one single cortisone injection. People will notice nothing special happened, no specific injury, just one day they notice a small lump on the back or the front of their wrist that slowly got bigger over time. What it is usually is a small little tear in the joint lining, a little bit of fluid escapes, and it causes a little balloon of fluid on the top or bottom of your wrist. That's not a tumor, it's not going to go anywhere, but if you would like it removed, I can help with that. Most patients initially think that it's a trigger finger, but it's not. It's the gradual contracture of your fingers down into your palm. They'll notice these hard nodules and ridges in their hand, and then over time they bring the fingers down. There is some speculation that it can be trauma-induced, such as somebody that plays guitar for, 20 to 30 to 40 years. There is a genetic component to it. This is extremely common. It's not a cancer, it's not an arthritis, it's not a tendonitis, it's a pure nerve-related issue. It's not caused by using a computer or a keyboard. What it can be is aggravated or exacerbated by using the computer or the keyboard. Tingling, numbness, a burning sensation, a heaviness in the hand, a cramping in the hand. Patients will complain of their pain being worse at night. I will try nighttime splinting. I will try anti-inflammatories. Treatment options would be to get a nerve test, what we call an electrodiagnostic study. They test the nerve and find out, number one, where the problem is, and if it's at the wrist, how badly the nerve is being affected. And based on that information, I'll either recommend or not recommend surgical release.
My specialty is orthopedic trauma, and that specifically covers any types of fractures from the shoulder to the wrist and from the pelvis down to the feet, to the most basic types of ankle fractures from people twisting their ankle, to elderly people with osteoporosis getting fragility fractures, people getting more significant injuries with fractures going into joints and affecting joint movements, to even high energy trauma like car accidents or falls from a height, which may result in shattered limbs. The main types of surgeries are fixing fractured bones using plates and screws or maybe rods inside the bones. Some of the techniques that I like to use when possible are minimally invasive or percutaneous techniques, which involve sliding plates along the sides of bones with a few smaller incisions that can help to preserve blood supply to the fractures and help avoid stripping the soft tissues away from the fracture to improve healing. My favorite thing about orthopedic trauma is seeing broken bones get back into the position that they were originally in. It's more about trying to put puzzle pieces back together. And also with some of the more complex orthopedic trauma, it's also about the decision making in terms of when is a patient ready to go to the operating room, how do you minimize the risk for infection, how do you minimize the risk for perioperative complications, and give them the best outcome possible.
It's very common. In fact, we do somewhere around 300,000 joint replacements every year in the United States. The most common reason to have a joint replacement is osteoarthritis, or wear and tear arthritis that has progressed to the point that the two bones are touching each other. You can see that it's quite narrowed, and in fact the bones are nearly touching on the inside of their knee. And this is what osteoarthritis looks like. When somebody comes in for an evaluation, I take some x-rays and evaluate them, how well they move, how strong their joints are, and based on what I find, we'll start treatment. We'll usually start with conservative treatments, meaning medications, injections, therapy, bracing, and other things. And then when everything has failed, then we'll start to consider surgical options. One of the things that I've been trained in specially is the anterior hip approach. It's an approach where we go into the hip without cutting any muscles, and we're able to expose the hip and do the surgery through this window, and that provides a better recovery, basically because we're not waiting for those muscles to heal back together after the surgery. For the typical initial hip or knee replacement, you'll be in the hospital for 3 days. Usually you're on a crutches or a walker for about 3 to 4 weeks. Usually you're taking pain medicine for about 3 to 4 weeks. And you have therapy, who usually come to your house for the first 4 to 6 weeks after the surgery. Usually by 3 months, you're feeling like you have a good joint again.
I did my residency in something called physical medicine and rehabilitation, which kind of looks at patients from a functional standpoint. So the patients that come to see me either don't want surgery or don't need surgery, because there are a lot of problems in the body that can cause aches and pains, even a lot of different types of fractures that don't require surgery. I saw everything from newborns to centurions, from a fractured toe to a concussion to back pain. I see professional athletes, I see weekend warriors, and I see someone who tripped over a stick in the parking lot at Publix. At the end of the joints, there's a smooth cartilage, like the smooth white part on the end of a chicken bone, that is called the articular cartilage. And that just really starts getting some wear and tear and being ground down. And so just that the bones have less of this protective covering. So this is a really good example of a relatively normal knee with a nice amount of joint space in between the bones. This is some very bad arthritis in the other knee. You can see that the joint space is almost completely obliterated so that it's bone-on-bone contact. Well, unfortunately, at this time, there's no cure for arthritis, and it's a growing problem. They're estimating that by the year 2030, that about 70 million Americans will have arthritis. The only definitive way to get rid of it is to do a knee replacement, but that's not necessarily the most appropriate first thing to do for anyone with arthritis. Also, not everyone is a surgical candidate, so there are a lot of other treatment options, including lifestyle modifications, some exercise, some weight loss, physical therapy, different medications like Tylenol, anti-inflammatories like ibuprofen, and a lot of others. Then also some cortisone or steroid injections. And lastly, these other injections called hyaluronic acid injections, or we'll just call them HA injections. If you looked at hyaluronic acid in a syringe, it's like a clear, slippery gel. It almost feels like a hair gel. It's naturally found in our knees. And if you take like a young, healthy 18-year-old knee, there's about 2 milliliters of this slippery gel in the knee. It acts a bit like a lubricant in the knee and also a bit as a shock absorber. Unfortunately, as we get older and as our knees get a little beaten up and injured, and especially with arthritis, our knees start making less hyaluronic acid, and then also the hyaluronic acid that they make is not of the same quality as it was when we were younger. And then just to make it even worse, if we have any swelling in the knee from arthritis, that's a watery fluid that can water down this gel and make it work less effectively too. People realized that these arthritic knees were making less hyaluronic acid and that the quality was poor. They thought, why not just inject more hyaluronic acid into these knees? The original types of hyaluronic acid came out in 1997. There were 2 different names. One was Synvisc and one was Hyalgan. Since then, there have been different ones that have been made. Suparts, Euflexa, and Orthovisc are the 5 major brands. Only Orthovisc and Euflexa are man-made, essentially, synthetic hyaluronic acid, and they're some of the newest ones. The older ones are actually made from rooster comb, and how they got that, I don't know, but and they still are made from rooster comb today. There are also different numbers of injections for each of the brands. Synvisc, the classic Synvisc, and Hyalgan, as well as Euflexa and Orthovisc are all 3 injections. Suparts is 5 injections, and then there's a newer one that came out in 2008 called Synvisc 1. which is taking all of the gel that you would normally distribute over 3 weeks and injecting it all at once. Absolutely. In fact, it's safer than the animal products. Your body will recognize animal proteins as not being its own, and so about 8 to 10% of people will have a kind of mild allergic reaction. The ones that we typically use either would have 3 injections or the 1 injection. The 3 injections are nice. It's 2 milliliters of hyaluronic acid in each injection, 1 week apart over 3 weeks. They have come out more recently with these injections that you put all 6 milliliters in one shot, which can be good for patients that, for whatever reason, can't or don't want multiple shots. But we do see more discomfort after these injections, these single injections, because you're putting more gel in, which expands the joint capsule more, and you do have pain fibers in your joint capsule, so you can have a lot of discomfort for a few days. I would either go in just to the outside of the kneecap, basically, or just the inside of the kneecap. And we go into the joint space underneath, and once you're in the joint space with the needle, it goes everywhere within the joint space. It doesn't matter which side you do the injection on. I usually base it on whether the person has any bone spurs or which one just feels better to me when I'm palpating the knee. Unlike steroid injections, where you do an injection and you have immediate improvement in your pain in about 2 or 3 days, and that it lasts for about 3 months, hyaluronic acid injections are very different. They work a little bit as a shock absorber and a lubricant, but more importantly, they're almost like a nutrient bath for the cartilage in your knee. I like to think of it like putting on moisture cream on really dry skin, that your skin absorbs it all and becomes healthier because of it. And the same thing will happen with damaged cartilage in your knee. It will get absorbed, and the hyaluronic acid will kind of buff up the cartilage that you have left. And then also it will rev up the rest of the knee so that it starts making more of its own natural hyaluronic acid. So because of this, it can typically take 4 to 6 weeks before you start noticing any benefit with hyaluronic acid. A lot of people don't like the idea of a steroid injection because they think it's a Band-Aid treatment, and in a sense it kind of is. Hyaluronic acid is different because it actually improves the health of the cartilage in your knee. I'd say the average is about 8 to 14 months, but the record that I've personally seen was someone who had benefit for about 6 years from one series of injections, and the second longest was about 4.5 years. But typically I'd say it's closer to around 1 year of benefit. Unfortunately, they don't, and I really want to stress that these are not a magic injection that are going to make everyone's knees feel better. Statistics roughly show that about 30 to 40% of people will have really tremendous results with these injections. Their knees will feel significantly better, and they will think these injections are the greatest things ever. Then there is another group, about the same size, of about 30 to 40%, that will notice moderate improvement. By that I mean they'll say, look, my knee is far from perfect, but it's better than it was before the injections. Sadly, there is a group of about 20 to 30% of people, though, who just don't notice much benefit at all. 6 months is the soonest that we can repeat it. So if you're not having any pain returning for a year, then we would wait until the pain starts to return before we'd repeat the injections. The statistics indicate the risk is about 1 in 10,000 to 1 in 15,000 people who may develop an infection. Otherwise, there's the inconvenience and the pain of having a needle, but I use the smallest needle that we can, and we do use cold spray to numb the skin before we inject. Lastly, I guess the only other downfall is just that you go through the series of injections and they don't work. But the way that I think about that is that it's almost like taking a vitamin pill, not feeling any different, but knowing that you've still actually done something to probably improve your health. Typically, it's no problem for you to drive home. It might feel a little sore either for a few minutes to maybe a few hours, occasionally a few days, but normally no issues walking out of here or driving home. I normally ask people to refrain from having a formal workout for about 48 hours after the injection. They can do some light exercise. Some people have actually found that you get a bit of benefit from doing light walking or swimming or exercise bike to kind of move the gel around inside the knee. And you can certainly continue on with your daily activities, go back to work, go grocery shopping, that kind of thing. But if you wanted to go for a power walk with your friends or mow the lawn, I'd say if you could put those off for 2 days, that would be ideal. There are a lot of hoops that you have to jump through and a lot of things that you have had to try first before you can get coverage for hyaluronic acid injections. First of all, you need to have at least tried some kind of activity modification, home exercise program, or formal physical therapy program, and then still had knee pain. You need to have had knee pain for over 3 months. You need to have documented arthritis either by x-ray, usually that's the best, but sometimes an MRI will suffice, or even arthroscopic surgery. You need to have tried a lot of different medications first. You either have to try and fail, or be unable to try because of a medical issue. Tylenol, non-steroidal anti-inflammatories or NSAIDs. Some examples are ibuprofen, such as Advil, Motrin, naproxen, which is Aleve, or even prescription strength NSAIDs, and some COX-2 inhibitors, they're called, like Celebrex and Mobic. Lastly, you also have had to try a steroid injection in the knee and either had only very brief improvement or no improvement. In Europe, they do a lot of hyaluronic acid injections into the hips and shoulders. In the United States, unfortunately, none of the hyaluronic acid products are FDA approved for any joint other than the knee, which means they are sometimes done in joints like the hip and the shoulder, but they won't be covered by insurance. You would come and see me. We would have a meeting and I would go over your history to make sure that you meet all the qualifications. I would have to document this in a note. Typically, if we're going through private insurance, then this note has to be sent away to your insurance company and you have to be approved for the injections. Depending on the insurance company, they either send the medications to us or to you or your primary care doctor, in which case we would contact each other and say, all right, the medication's here, let's set up the dates and times for your injections. If you have Medicare, we do have a supply of the injection medication here, which we can use for Medicare patients. We don't have to get prior authorization. However, we do have to still meet all the requirements, like having tried Tylenol, ibuprofen, steroid injection, etc., even for the Medicare patients. I think it's a really great option right now. I did it to my own father's knee, and he had, I'd say he was in the moderate response. He is an individual who needs a knee replacement, but he's just trying to delay it. But I'm a big fan of these, and they're very, very popular worldwide.
When you consider the fact that Paul Meli founded this organization and was a solo practitioner for a number of years, he really took the time to investigate what the community needs.
He's growing with a really exciting group of young physicians fresh out of some of the best training programs in the United States.
We have a wide variety of specialists here. We have hand and upper extremity, non-operative physician. sports medicine, trauma, joint replacements.
It's not a group of general orthopedic surgeons all doing the same thing.
You know you're going to get your injury or ailment treated by the person that's best able to do so.
I think that the physicians that we're hiring now are very compassionate and care about the patients that we're seeing.
I think we've got a very dedicated staff here that's very hands-on, and it's a very nice personal experience.
Millions of people suffer from it. Hip pain. Now there's a new procedure that could work better for you than hip replacement. Dr. Sean Kniff will answer questions you're likely asking coming up.
Well, some good news for millions of people who suffer from hip arthritis.
Yeah, it's a minimally invasive surgery that can actually repair a variety of hip ailments. CBS 4 health specialist Dr. Sean Kniff is here to tell us about it. Doctor?
That's right, Elliot. Hip pain affects people of all ages, from their teens well into their 70s and 80s. A total hip replacement is not the best option for everyone. Now, thanks to improved technology, there's a less invasive procedure that's bringing relief and a much quicker recovery.
It's hard to believe 31-year-old Tanya Lawlins has suffered with hip pain for years.
I had a lot of hip popping, a lot of joint pain.
The pain was having an impact on her daily life.
Keeping me from walking, you know, with my son, walking with my husband, taking walks on the beach and going to the mall.
When other treatments failed, Lawlins learned of a minimally invasive hip procedure called arthroscopy. Dr. Paul Meli, director of the Shoulder, Knee, and Hip Center of South Florida in Fort Lauderdale, is one of a few doctors in the country to offer this alternative to hip replacement.
A donut of cartilage that goes around the socket called the labrum that we can fix. There's a number of ligaments that attach the ball to the socket that can also be repaired, and if there's any free pieces of cartilage stuck in the hip, we can also take care of that.
Dr. Meli says symptoms of hip problems may not be what you think.
The symptoms typically are groin pain. People think the hip is on the outside part of the leg, but actually it's in the groin pain.
Beyond pain relief, the benefits of hip arthroscopy include smaller incisions, quicker recovery, and longer lasting effects. Patients will also need physical therapy after the procedure. Melanie Henderson with Imperial Point Medical Center says it's important to increase strength and mobility.
We see them to get them up for the first time, teach them their home exercises, coach them through their ice regime, and how to manage the first 48 hours post-operatively.
Lawlins says she's pain-free and back to doing the things she loves.
My pain is totally 100% went away after the procedure.
Now, Dr. Meli and other experts say there are many other symptoms of hip problems that include lower back pain, difficulty walking, and in particular, people who have pain at night while they're resting.
Really?
Boy, that's tough.
Yeah. Well, people of all ages have problems with their hip. Is there a certain type of person that might do better with
Well,
this?
this kind of fills a gap. It actually will stave off from people actually having to go to a hip replacement surgery. So that's one good thing here, which is really important for young people. So a lot of young people were more athletic than ever before. We're getting a lot more injuries than ever before. And some people, our own Joe Martin, who was a sports kid, who need a hip replacement. So it's great for patients like that maybe it'll buy them a few years, maybe a couple of decades before they need a hip replacement surgery.
Sooner or later they'll need it, though.
Well, maybe. Not in all cases.
Thank you, Doctor.
Thank you for allowing Meli Orthopedics to be your orthopedic specialist. Myself and the other physicians and our staff look forward to providing you with expert orthopedic care in a warm, friendly, and efficient environment.